The topic given to me is Introduction to Patient Safety. This is a very important topic, a very upcoming topic which most people are not aware about. But also, most of the stuff that we are going to talk about is actually really very common sense. So, it's no rocket science, but we need to be aware of these things. So, what all will we talk about? What is this discipline? What are the patient safety scenarios in India? Let's start with these two topics. So patient safety basically means that while the situation nowadays is that healthcare has become so much complex with devices, with complex surgeries, with multiple medicines, uh, medicines with very high potency, but also a lot of side effects. So there is real danger of patient safety problems occurring if we are not aware of them. So ensuring the absence of preventable harm to a patient while we give patient care. That is what patient safety is about. Now, who are the people who need safety in a hospital? Of course, nowadays, given the current scenario, people would say staff and doctors. Well, yes, staff, doctors, visitors, patients, everybody needs safety, but we are going to talk about patient safety. So in India, it was seen why we are talking about it today, why it has been put up as a part of the foundation courses, because it's a very underreported scenario in India. Even hospitals with very high standards of healthcare practice are not really trained to detect where all the safety errors occur. There are a lot of lacunae right from drug delivery and prescription to when the drug or whatever the modality of treatment is reaches the patient. So programs and workshops like this, what we are doing today, attempting to do in a half an hour class, is to improve the healthcare scenarios and decrease the margin of error. So while we say in the most simplistic terms, we are all aware of the maxim primum non nocere, meaning first of all, a doctor should never do any harm. So we come to what was historically the origin of the patient safety concept. And who is the first person to be credited with this? Any guesses? Who was the first person who talked about primum non nocere? Who is this gentleman? It's not Rabindranath Tagore. Yes, of course, this is Hippocrates, the father of modern medicine. He's the first person who even told, uh, adages like diseases are caused by other factors, not by superstition and gods. He is also credited with a lot of clinical science. One of them is detecting clubbing. So he had written that I will benefit my patients according to my greatest ability and judgment, and I will do no harm or injustice to them. However, so that is the basic guiding principle whenever we are treating patients. But a recent article in BMJ had talked about, is it an impossible oath? Can anyone even stick to it? From Hippocrates times, when it was decided that no harm should come to the patient, there has been a paradigm shift in the thinking that patient safety errors will be there. During the course of treatment, there are bound to be some problems that the patient will incur. This is because of the complexity, the multidisciplinary teams, the highly potent methods that we use. So is it an impossible oath to stick to? Because harm to avert harm even with most beneficent intentions is very, very difficult. However, if we think of that our intention is to be useful and that is our guiding principle, then the Hippocratic oath will remain possible even in these times. So now in 1999, there was a paradigm shift by the Institute of Medicine declaring that to err is human. How to decrease those errors is the whole point here. So we have to make systems in such a way that human error, there is an error, there is a system which checks human error at all points so that it is intercepted before the patient undergoes any harm. So every error will have a root cause which needs to be identified. One unwillful error will be a miss. However, repeated errors, the fact that we are not getting into the root cause and not identifying it, are criminal. So we need to build safer health systems to reduce and prevent errors. A bad system will always beat a good person every time. So towards this, WHO came up with a global action plan in 2021 with the vision of a world in which no one is harmed in healthcare. Every patient receives safe and respectful care every time, everywhere. So we have to come up with strategies both in terms of individuals, institutions, and national frameworks, how the patient safety can be improved upon. WHO has had many initiatives in this direction, and at present, the Medication Without Harm initiative is still on for making medications globally safer. So the next maxim that now we have is that to err is human, but to prevent error is divine. So we talk about what are the, how do adverse events still occur? What is the Swiss cheese model? So occurrence of adverse events, like I said, is pretty common, more than what we all think. It is one of the 10 leading causes of death and disability globally. Even in the West, every 1 in 10 patients gets harmed while receiving hospital care. In low and middle income countries, almost 2.6 million deaths occur annually because of unsafe care. The sad or the heartening part is that 50 to 70% of these adverse events are preventable. And the most detrimental problems are because of diagnosis, prescription, and use of medicines. And yes, if we prevent these errors, if we work towards patient safety, we can also save a lot of expenditure, and also we can end up with better patient outcomes. A simple step, for example, like communicating better with the patients. This is more important when we are talking about antihypertensives, oral anticoagulants, etc. So if done well, it will reduce the burden of harm by up to 15%. Patients do not remember the doctor's prescription. They always remember what the doctor or whatever the healthcare provider told them. They always remember that. The extended families remember that. So what is the Swiss cheese model? In healthcare, there are a lot of holes at every level. And these, when they align, then it becomes a problem, because then it translates into a patient safety lapse. So if we talk about a positive Swiss cheese model, for example, in case of the recent pandemic, none of the layers of these protection were by themselves foolproof. But if they all came together, we could get beyond the pandemic. Likewise, in healthcare, in patient safety, what happens is that there are multiple levels. These are all barriers, and at each level, either things can go okay or some small lapse can occur. When, if at the next level that is intercepted, then we are creating patient safety. If, however, it goes unchecked and all the errors align, then an active error will reach the patient and the patient may undergo a problem. So when we assume that individual perfection is possible, we cannot improve safety. When we realize that errors are possible, then we work towards a safer system where the entire system is open and transparent and a safety culture prevails. Now, errors that can produce harms, how do these errors occur? They are diagnostic errors, there are errors of medication, interactions between drugs, of course, healthcare associated infections, unsafe surgical procedures, unsafe injection practices, unsafe transfusion practices, radiation errors and leakage, undetected sepsis, very important in today's scenario. If the whole system is really alert and somebody sees that this patient started having fever with chills again, or there is a neutrophilia, or that this patient who had pyelonephritis earlier has started having backache earlier. So again, so the sepsis may be checked before it goes, uh, you know, on to have catastrophic problems. Likewise, not managing to check or prevent venous thromboembolism will also have disastrous consequences. So these are the steps that we should, these are the points that will, if we remember these, then they will ensure patient safety. I'm not going to talk about the others because I think the other lectures have covered these. Little bit about medication errors, which is very important, because we use so many medicines now, some of which are so potent and so have such a narrow margin of safety, and there is so much polypharmacy which goes on. So this deserves prioritization. Medicine used to be simple, ineffective, and very safe. Now it is complex, very effective, and also potentially dangerous. So the medication errors will be errors of omission or giving at the wrong time, wrong rate of administration, wrong route, giving it wrongly, wrong patient. Very important. Right patient, right medicine. The basic adage to remember. And then, of course, there will be monitoring or compliance errors. In real life examples, uh, I think for the DM students, this will be really simple. For the MD students, if somebody can attempt to answer the first one, a patient who was started on a new antihypertensive agent and after 2 to 3 days, she was discovered to be in altered sensorium. What could it be? Hyponatremia with a diuresis, a very likely scenario. Likewise, Mr. C, who was started on alendronate, had severe dyspepsia and retrosternal pain. Why? Because alendronate must be taken with a full glass of water and patient should be told to remain upright. Even a simple thing like picking up a balti to have their bath can precipitate this sort of dyspepsia. This is how errors occur. If somebody writes diazepam for diltiazem, imagine what may happen. If you don't specify a maximum daily dose for a painkiller, patient may end up with nephropathy or with bleeding. Somebody who has not been told that they have been started on pregabalin or an alpha blocker may have a fall and may have a head injury or a fracture, especially if they are frail, because they've not been told to be alert to these problems. In Kolkata, in real life examples in India, this happened that a nurse gave to a 9-day-old baby. Instead of vitamin K, the baby was given 50 milligrams of tramadol. So such a, one error, and look at how it would magnify. So this is what we have to sort of try and remove. Then there are simpler errors such as crushing medications which are entry coated and should not be crushed. We always see our patients that they talk about कि मैंने आधी तोड़ के खा ली, but it was an entry coated tablet and should not have been cut. It was a non-scored tablet. Inadequate fluids with medications like I talked about alendronate. Likewise, doxycycline induced pill esophagitis is real. Patients sometimes do not know, they are sleepy, they eat it at night, and they end up with a very bad esophagitis. Allowing patients to swallow sublingual tablets because they've not been explained, not mixing solutions properly. So, prescribing, storing, dispensing, and even preparing for administration or giving a medicine at any of these stages, the error can occur by any person who's involved in the medication process, by the patient themselves, by their family members, by the doctors who write these. So everyone will have a role to play in medication safety. They have to know what is the medicine, they have to check, they have to ask. This has to happen at every stage because a small error can make a huge difference. What are the 10 medication administration rights? Right patient, right reason, right drug, right route, right time, right dosage, right formula, right action, right documentation, and right response. Nowadays, we talk about biomedical wastage. So not only give the medicine safely, keep them safely, and also ultimately toss them safely. So through technology, how can we improve medication safety? We can use smart infusion pumps. Dr. Anjali just talked about electronic health records, and we can have barcode scanning on highly potent or highly toxic medicines. However, over reliance on technology always is a pitfall, and human attentiveness will always be critical, especially when we are dealing on one hand with humans and on the other hand with technology. So adverse drug reactions are inevitable, but medication errors are preventable errors. Polypharmacy is a huge risk. Pediatric and geriatric patients, of course, are highly vulnerable. Then there are drug-drug interactions, drug-food interactions, and drug-disease interaction. Drug-drug interactions, this is the list which most people are know about. Luckily nowadays, we all have apps. There is Medscape, there's UpToDate. You can just put the name of 2 medicines and you know whether you should be combining them or not combining them. Likewise, drug disease interactions, something which still a lot of people lapse with this, that when in monsoon fevers, people start having NSAIDs for their fevers, not realizing that this may be dengue, and they come with bleeding. Sometimes it is fatal. Any thrombocytopenia which the patient may have a pre-existing thrombocytopenia is given an oral anticoagulant. Menorrhagia being treated by the gynecologist, cardiologist or cardiothoracic surgeon or neurologist giving the patient oral anticoagulants. So there are deadly interaction between the two. What happens then is a sentinel event. This is a event which is unplanned, not scheduled. It may result in death or serious harm, or there is huge risk for physical or psychological harm. Even if there is no serious physical harm, there may be psychological harm. These are sentinel events because they signal the need for immediate investigation and response. So ICU, again, a lot of you may be working in the ICU. It's a very it's a, what should I say, it's a place where whatever can go wrong may go wrong, and the margin of error unfortunately is really tiny. Uh, it's a complex environment. The working conditions are really difficult. It's a high stress environment for everyone. Patients are all high risk, very sick, sedated. They are on multiple meds. Multidisciplinary teams are looking after them. Admissions come in at all times. There's a high turnover of patients. Sophisticated technology and equipment is all around, and there may be lack of continuity of care at discharge from the ICU, because ICU teams are most often not, tuned to writing discharges. We talk about high alert medicines. These are medicines such as insulin, um, IV electrolytes, opiates, narcotics, theophylline, anticoagulants, and anti-epileptics, which have a very small margin of error. It's not that they will have more frequently, they'll give side effects. It's just that their side effects may be really very, very deadly. So we have to be very sure we can put these labels saying high alert medication and double check the drug and strength when it is being administered. And for all high alert medicines, for every person who's involved in writing or administering these, if there is a change in dosage, please cross it out and rewrite properly instead of overwriting. Be very wary of telephonic orders, whether they are between consultant and resident or between resident and the staff. Telephonic orders should be avoided in terms of whenever we are dealing with high alert medicines, and in wards or in pharmacies, in all the stores, they should be stored in different locations from the other medicines, and there should be proper labeling. What are LASA medicines? These are look-alike and sound-alike medicines. Big pitfall. Amlodipine, amitriptyline, atenolol, allopurinol. There are so many medicines. First of all, we have tens of thousands of medicines. And secondly, this lot of them have similar sounding names. So tall man lettering is a thing to use. Even when we all are writing such medicines for our patients, for our staff, we should use tall man lettering, which means that if there are two medicines which sound similar, then the letters which are different, use them in color, use them in bold, so that the person who's finally utilizing the final common pathway, I don't think the picture is visible very, very well. It is hydralazine and hydroxyzine. Both are from the same company, both are the same strength. And they have used Tallman lettering here to emphasize which is the medicine, so that at a glance, one knows what is it. There are pitfalls like this also. There are medicines like pantoprazole, very innocuous, and midazolam, an anesthetic agent, which are both available by the name Medzol in the market. Then failure of communication between teams, again a very big problem. Very often the handoff is not smooth, somebody is busy at the time of handoff, not really telling what happened. So this is again a real life scenario. A patient had labetalol, hydralazine, and extended release nitrifedipine were all crushed, given by nasogastric tube. They were all extended release, they should not have been crushed. She had severe bradycardia, hypotension, resuscitated. Next day, no handoff, no error recording, no looking back into what happened, and the same drugs she got the same way the next day, and she paid with her life. Again, lot of jokes about this. Everybody gets WhatsApp jokes. If you are a doctor, you forever get WhatsApp jokes about this. My children tell me that I was destined to be a doctor because my handwriting is really very bad. So illegible handwriting by doctors. And I don't think that my handwriting is so bad, but sometimes when I read my own prescriptions, I'm unable to read. So I think my children are right, and the pharmacists do have to second guess such doctors. So we have to insist on proper drug storage, adequate storage environment. LASA or high alert medicines should be organized properly. The emergency trolleys should be organized properly, because they will have a lot of medicines which can cause potential harm. Auxiliary labeling, like saying dilute before administration, for inhalation only, may cause drowsiness or dizziness. These are like at a glance, you can see these labels, and they add to patient safety. Dr. Anjali also talked about it. Documentation is very important. The do's and don'ts of documentation, that if you do not chart it, it did not happen. Everything must be written with a legible real-time record, and records should not be tampered. With increasing number of consumer protection cases and all the courts asking for records, this is in the coming years, when you all are practicing or have your own nursing homes or are practicing in big hospitals, these things will really become all important. What is medication reconciliation? Very important. Actually at every transition of care, we should ask the patient what all is the patient supposed to have and what all is the patient really having. Every few weeks, I make some of my patients just pull to all their thellas and look through what all they are having from various private doctors and SGPGI departments, and they will be having at least 4 types of antihypertensives, 3 types of proton pump inhibitors, and 3 types of antibiotics, and maybe 4 or 5 types of painkillers. So one has to really sit down and tell them that all these you're duplicating medicines and these may cause a lot of harmful side effects. So this should be definitely prevented. And so the Ministry of Health and Family Welfare has come up with a National Patient Safety Implementation Framework called NPSIF, which is in place from 2018 and is going on till 2025, when it will again be renewed. So in that, they have said that patient safety is the fundamental element of healthcare. All patients are entitled to this. Like I said, that to err is human, but to prevent those errors is very, very important. So the components of NPSIF are safe surgical care, safe childbirth, injection safety, blood safety, medication safety, which we just talked about, medical device safety, all important in today's time, safe organ, tissue, and cell transportation and donation, biomedical waste management, prevention of healthcare associated infections, and research into patient safety, like how can we make patient safety better and better. In the international patient safety goals, why it is important to talk about these is that I talked about the national goals. In this, there are a couple of more common sense things which are very important and which we must amalgamate with our national goals also. Uh, Goal 1 is identifying patient correctly. I earlier also talked about this. Right patient, right medicines. Likewise, right patient, right treatment is a very important part of patient safety. Identifying the patient correctly, improving effective communication and feedback between teams. I talked about high alert medications, which is goal 3. Goal 4 is safe surgery. I'm sure you all already had sessions about that. Goal 5 is reducing the risk of healthcare associated infections. Goal 6, again, something very important, with increasing longevity, the real risk of falls, especially in the elderly or those who are really frail or have osteoporosis or any other underlying conditions, reducing the risk of patient harm resulting from falls. This could be structural, such as having a ramp in place, not having a step in a ward where we know that the elderly uh, are very often get admitted, having grab bars at the side of the toilet seats so that when they get up from the toilet, they do not end up falling. And also looking into what, suppose it's a patient with a diabetic neuropathy, what kind of footwear is the patient using, or an orthopedics patient, what kind of footwear is the patient using, and medications which may cause dizziness or orthostatic hypotension, uh, so that falls are prevented. So to conclude, just awareness of risk factors is not enough. We must be proactive and vigilant. We have to be transparent about errors. We have to try and educate others, and so that the same mistake is prevented in the future. Ek baar ho gayi, that's okay. It's fine as long as it was not something lethal, but we must learn from our mistakes. So we have to shift, every institution has to shift from a culture of blame and shame or name, blame, and shame to an environment of trust and transparency. And safe providers only can provide safe care. We have to come up with voluntary reporting systems about errors which may have occurred. Critical incident root cause analysis should be there as part of the audits. Develop blame-free health systems, encouraging learning and sharing experiences, developing overall a culture of patient safety. Medications are really very good tools in today's times. We have really, really good medications, but they should be used safely and wisely. And medication safety, all of us are stakeholders, whether it's the doctor or the nurse or the pharmacist or the patient or the patient's own care provider, family member. It starts with all of us. To conclude, what is safety? Always sense the error, act to prevent it, follow safety guidelines, whatever you may have for your institution, for your department, for the particular kind of case scenario that you deal with. Inquire into accidents or deaths which were unexpected. Take appropriate remedial measures so that they can be prevented the next time. And finally, it is your and my responsibility. It is everybody's responsibility. Thank you.